Thank you, Cliona. I mean, it's so clear that you are living inclusion and that it's core to who you are, actually. So thank you very much for that. So if I could invite up the other speakers from the session as well for discussion. Welcome back. I might start with a question, and it relates to the language of inclusion, because I think, and you've touched on this, Cliona, I think the language of inclusion is very, very complicated, and sometimes we're a little bit afraid of it, and sometimes, as you say, we overcomplicate it. So here's a small question, but it's a big one. What do we think about the word vulnerable?
See, I don't like that word because I think that puts the fault on the person. So there's nothing wrong inherently with being a traveller, for example, that is wrong with you. It's how our society is structured. In a similar way to disability, where if you have the proper ramps and things in place, it's not the fault of the person who has the mobility, you know, who needs a wheelchair. It's us as a structure who need to make it. So I personally don't like the term vulnerable. And I would always use a term like marginalised or excluded, where you're putting, it's us as a society, unfortunately, who are doing that rather than something in the person.
Right. Noreen, would you agree with that? Or?
Yeah, totally. It's, you know, it's probably down to the labelling. You know, everything is labelled nowadays. And I guess with the children, like my children had, you know, they had no choice in the situation. And what we want to do is make them feel as involved in everything as possible, and not, you know, and not let them grow up feeling that they were different. It's very important that they didn't feel different. So I would be in total agreement.
Okay. Yeah, I sense that you have a view on this, David.
Yeah, as a philosopher, I like definitions, and words are important. But another one I came across actually when I was writing my talk was minority, and lots of minorities feel the same way about that, because minor implies lesser, even though it's fairly acceptable to call people that. So I think you've got to be inclusive in your use of terminology. Vulnerable, I think I don't have so much of an issue with, but it does imply is that kind of lesser aspect to it as well. So marginalised is a better word, because it's like what other people are putting on them rather than something that's intrinsic to them.
We might just pick up on some of the things that I'm seeing coming through Slido, and that's around inclusion and exclusion. And Fidelma, I might ask you about this, because you've obviously thought a lot about it. And is there an onus on us to put the focus on why we should, to explain why we would exclude people rather than include them, or yes. Not include? Yeah.
So certainly in the trial we've just completed, I went back to the literature to look at what was done previously, and of course there was a lot of white Europeans, there was a lot of segregated BMI categories, there was a lot of higher socioeconomic status. So when we were talking about the ladies we wanted to include, we kept the inclusion criteria strong and minimized the exclusion criteria. So every exclusion criteria, I said to myself, is that really necessary? So our exclusion, like the only women who couldn't come into the trial were if you had twins or triplets, because it was only for singletons, if you had a small baby on scan, because metformin can possibly affect the size of the baby, and if you had a medical contraindication to the use of metformin, like you had kidney disease. But apart from that, you know, people had, you know, said people with a little bit of depression or a little bit of anxiety. I didn't say, oh, they have a mental health issue, I'm not including them. Or people who were unemployed and maybe didn't have enough money, and you wonder, could they get to see us? Could they, you know, participate wholly in the trial? For me, it was that they should be included, and if there's a difficulty getting them in to participate, I need to find the solutions.
Yeah.
You know, so I think focusing on inclusion, minimizing exclusion to absolutely what do you as a clinician feel that is absolutely an exclusion criteria. In other words, if you include that woman, you're going to do more harm than good. So I think you have to think like that rather than. And coming back to the question of vulnerable population, I hate that word. There's nothing vulnerable. A beautiful pregnant woman, she's really happy to be pregnant, she's going to have a baby. You know, I mean, what's vulnerable about that? There isn't really. But I think the word for the clinician makes the clinician ponder on what they're doing, and they say, now I need to be just extra careful with this lady because there are 2 patients here.
So do you think are you saying, do you think there's a place for it sometimes, just to have that thoughtfulness around it? Or
projecting it to the patients,
right.
But for the clinician and the researchers, you know, if you have somebody with a disability, for example, you're going to be more aware of, can they make it up to here to see me, or do I need to go down there? Will that wheelchair fit in? Similarly, with a pregnant woman, you have to say, right, I know this medication is going to work and her sugars are fine. Now, am I absolutely sure that what I'm doing is okay for this baby?
Yeah.
You know, and you have to kind of, I think, just be more cautious when you have a population like that. But I don't think we should be telling that woman she's vulnerable.
Yeah, I think just being thoughtful in the language around it, yeah. David, is it your experience, or from what you've seen, that people are becoming more inclusive?
I think they're thinking about being more inclusive, but they're still not reflexive enough. I mean, in philosophy, we talk about moral imagination and like putting yourself in someone else's position, thinking laterally. And I think sometimes researchers don't do enough of that. And one thing I meant to mention in the talk was one size fit all doesn't work. All areas of research, not just inclusion, it's not all quantitative, it's not all men, it's not all, you know, and so on and so on and so on. So I think just prompt, and I think I agree, but that's why I was hesitant about, yeah, you shouldn't be telling someone they're vulnerable, but it's a useful reminder for people to internalize, even if that doesn't capture the key concepts necessarily. And it's the same, it's just making people stop and think. So I think people are aware they have to be more inclusive, but they're not used to it yet, so they need to keep practicing.
Okay, yeah. Cliona?
Just picking up on that, I think it's really important to have diversity in education and in research, and recognising that some people are going to need extra support to get into third level education, but things like access programmes in universities and extra supports are really helpful in making sure you have a diverse pool of researchers and academics and practitioners.
Thank you. One thing that's coming through very strongly is people want more practical advice. So you all gave really, really good practical advice on how we become more inclusive, but particularly they want advice on how do we reach people. And I think that's probably more difficult for those who are not patient-facing, especially if you're not in a clinic. So do any of you have any additional advice beyond what you've given on how you reach people?
I would look for who is trusted in that community. So say, for example, in Travellers, there's a really brilliant programme of traveller women being kind of health advocates for their community. So look for who has respect and trust and go to them first, and then they will, you know, work with you to extend their networks. If that makes sense, I think that's a useful tip.
Yeah, yeah.
I would just
David.
to second that. I mean, not in the context of research, but in organ donation. Obviously, some minority communities are in, I'm using the word, some marginalised communities are more in need of organ donation, but they're less likely to donate their organs. And faith leaders and community leaders and so on were really important to bring on board, and then they could support this and encourage people towards it. And I think it's the same with research.
Yes. Noreen, in relation to that question, I think knowledge and awareness of the public around clinical trials is going to be helpful. In your experiences, when you talk to your friends, family, community about what you've been through, do they know what clinical trials are? Are they understanding the value?
No, is
Okay.
a simple word. They're
So-
not. And I'm only speaking from a lay point of view. You know, as a family, we wouldn't have known what clinical trials were. To this day, we still wouldn't if our situation had come to our door. And then obviously it's in your face and you become educated. And through the hospital, in fairness, there was, you know, the liaison nurses in St. John's Ward were fantastic with offering information and educating you, because they had to educate you in so many things around this new way of life that was going to be yours for the next number of years. So there was great education given, but that was only because we were in the direct line of fire. You know, No, my friends wouldn't have a clue, only that, you know, sometimes they come to events if there's fundraising and they would hear what I say. And, you know, but it'll kind of go in one ear and out the other because it's not directly, it doesn't have the impact that it would have on people who are directly hit by it. So I think perhaps, like I know for a fact that dealing with new families on the ward, let's say, and explaining to them from a mother who has already gone through it and they're just about to go through it, they really take on board the experiences and not, I won't say advice, but listening to the stories that other parents have had to go through, and they really value that information because it's me talking to them, it's mammy to mammy, it's not professor whoever talking, they're not afraid to ask questions. And that's, I think that is one of the big problems as well. When you're in as a patient or a patient's mother or father, and you're surrounded by this great team of people that you're giving your child over to them, you're trusting them that they're going to make this child better. Some people are afraid to ask questions because it can be quite a daunting environment. And, you know, the usual, like, this is probably a stupid question. In that situation, no question is a stupid question because ultimately this is about the sick child or the sick, whoever the person is. And ultimately it's about the child. So they need to be educated. But that's, again, that's because it's in that environment.
Yeah, I mean, that's fantastic that you're doing that, and great to hear that that's happening, and I can really see the value of parent to parent. And,
yeah.
And I suppose, you know, to some extent we're all in a bubble where we think people know about clinical trials and clinical research, and so I guess it's something we all need to think about in terms of how do we get better at communicating with the public. As I think it was Laura said earlier, COVID did us a big service in that regard, but still so much more to do. Another question that's coming through is around capturing the data, and you talked about this, Cliona, and if we're not measuring diversity, how do we know if we're involving people? And Fidelma, you clearly did that, and is there something that you would advise people?
I guess diabetes is a great leveller. It affects all different types of ethnicity. So when you're in a clinic where 12.4% of the pregnant women that are coming to that service have this condition, you get all these ethnic groups. So, you know, I find it's not difficult to capture it for diabetes. So in filling up our pro forma in a clinic about diabetes and the type of diabetes you have in pregnancy, we have a tick box on our online system about ethnicity and so forth. So we capture it quite a lot. So, but again, you know, in clinics or in situations where you're not actively doing that, you have to put in place a process to do it. You know what I mean? The process has to be thought through and made easy to capture it.
And I think there are a lot of fears around GDPR and a lot of blockages around that as well. Yeah. David, you talked about, I think it was a Wellcome Trust piece of work, and I think they have something else. I'm trying to remember what it's called. It's like the DAISY questions, or there's something the Wellcome Trust have done where they actually show you how to ask questions. What are the correct questions to ask? Now it's UK based, but it's really, really helpful actually. Is there anything else you would point people to in terms of the practicalities of it?
No, well, just the Wellcome work is really for people who want to be very proactive in doing diversity and gender analysis while designing research projects. That's what the framework I mentioned is about. But the Include study is just a really good comprehensive overview of who's neglected, why they're neglected, and it makes some recommendations about how to include them as well. And I think it links to lots of other studies too. I mean, and I think obviously context varies, but the lessons from other countries can be applied as well and adapted to different circumstances.
Thank you. Okay, we might open it out to the floor. So does anybody have a question? And I just implore you, keep it short if you don't mind. Down the back there, if we get a microphone. Oh, you have one.
Hi, for Fidelma. Your study, you indicated 80% had third level education. And obviously, point made earlier about the health information literacy and stuff. Did you ascertain the education level of the 400 decliners?
No.
Yeah, short and sweet.
Excellent, just what we want. There's a man over there. Sorry, just
But
hold on for the microphone.
Just coming back to that whole thing about university educated people versus none, that really points out to me that the clinical research we're doing, if it's going to have impact, has to move out from level 4 hospitals. So we can't just do trials in level 4 hospitals, because if I had this trial running in Castlebar or Letterkenny, I wouldn't have 70% or 80% tertiary level. So, you know, I think that's an important factor that we need to consider. And with the new development of the regional health authorities, that should be something that should be prioritised, that research goes out into the area that you're covering.
Yeah.
Yeah, that one deserves a clap for sure.
All right.
Yeah. And I think we all need to bear that in mind and all be advocating for research to be at the heart of those new areas.
Well, answering the question, what are you trying to do and what population are you trying to improve the outcome for? Yeah.
Question and
Could I ask
comment.
you just to introduce yourself? Sorry, I should have said that.
Anthony Staines is my name, from DCU. So the comment is that even after you've done representative trials, the big problem is implementation. And we do almost no work in implementation, and not just in this country, but across Europe. The question is this: I work with people with intellectual disabilities who have complex medical needs and almost never get involved in clinical trials. Any thoughts on how to improve that?
Anybody want to take that one?
So I think sometimes it's down to the funders making sure that they're aware of neglected areas, because that shapes what research is done. I think it's great to see so many representatives from different ethics committees and the National Research Ethics Committees, because I know I see somebody here from James's. Our Research Ethics Committee have been really supportive of working with groups where they could have gone, oh no, it's too risky, but they've been on board. I think those are two things that would help.
And I guess it's also about taking the time and to produce materials that are appropriate and to give the explanations in an appropriate fashion. And did you want to come in there, David?
No, there's a question over there that I don't think you can...
Oh, okay.
Yeah, sorry, that was...
That's okay. I've actually promised one over here first.
Thanks very much. Olga Cleary, HSE R&D. I guess my question very much goes towards the population health framing in terms of inclusivity in research. And I think today we're hearing a lot in terms of the responsibility of the researcher, but in terms of that population health framing, the policy approach to research, how can we ensure that we're taking our responsibilities seriously in terms of the structural supports that researchers require?
So you're talking about what are we doing at a national level around policy to really insist on this?
Yeah, to insist on it and to support it. So I think we're hearing from the converted in terms of trying to include marginalised groups within research. But what are funders doing? How can we support researchers who are committed to including?
Okay, thank you, Olga. We don't have any funders on the panel, obviously. Does anybody want to speak to that, or maybe their experiences of applying for grants? Do you think anything has changed in recent years? Is there any higher expectation? I think what we're definitely seeing is a higher expectation around PPI. And I think we're growing into a space where we're also thinking about diversity in that context, and questions are starting to be asked around that. And I think your point is very well made, Olga, and it's something that needs more time and thought, a lot of thought, but we do need to move on it.
I think something around supports for marginalised groups to engage in PPI, so you need to do it in an ethical way, and to do that they may require extra supports and mentoring or whatever it is. I think that would be a really great thing to invest in.
And maybe it's even budgets allowed for in grant applications or timelines and so on. So David, who had you spotted here?
Lady there.
Yeah.
That's
Thank you. Angela Clayton-Lee, Cancer Trials Ireland. Just with a focus on maximising inclusion, could I ask Fidelma maybe about I think it was about 200 women whose partners objected to their participation. and whether or not the reasons behind that were looked at, and if so, were there any learnings that we could apply? Thank you.
We didn't specifically look at the reasons the partners didn't want their women to go into the trial. And and it would happen like you approach a woman, say, you know, we're doing this trial, this would be the benefits, these are the risks, you would be suitable. She'd say, oh no, my partner doesn't want me to get involved. So once you got a no from the beginning, we didn't really try and explore that. But maybe, you know, for a future IMP trial in pregnant women, that would be a sub-study we should look at. I was surprised that the number were so small. I thought it would be significantly higher.
And again, just in organ donation, the NHSBT capture data on the reasons people or families refuse to allow organ donation, which is really important for developing strategies to make that more inclusive and bring families with. So I think for people who are refusing to take part in research for whatever reason, capturing more reasons would really help facilitate inclusion as well.
Excellent point. Okay, we have time for one final question, and we're going to take it over here. Just hold on for the mic and introduce yourself, please.
I'm an obstetrician in the North Inner City, and so I have a comment just in defence of the word vulnerable. There's no question but that I would argue that pregnancy is a state of vulnerability. And together with Fidelma, my own experience in recruiting pregnant women to a clinical trial, and most markedly actually during COVID, when partners were typically not in the hospital at every visit and not in the hospital at the time of a discussion around participation in clinical trials, that a very interested pregnant woman who took all of the literature and came back with a view to having their screening and consent visit returned, very commonly to say that their partner didn't want them to participate. So I do believe that pregnancy diminishes a woman's ability to make autonomous decisions in a way that in this day and age is very disappointing.
Thank you.
But is my experience.
Any final comments on that one? I thank you for that. I think it's important that we have these discussions about the language, coming back to where we started, the language, because it's a very, very important part of it, and it needs thought. We're going to end it there. Time for lunch. People will direct you to the lunch area. I think we are coming back at 2:15. 2:15 sharp. Okay. Thank you. And a final round of applause for the panel, please.